Okay, thanks everyone for joining us today. Very delighted to introduce Swathi Sekar, who is a PhD candidate in the Department of Behavioral, Social, and Health Education Sciences at Emory School of Public Health. Swathi's research interests include the intersection of diabetes prevention, clinical management, and implementation sciences, particularly among South Asian communities, both in the US and globally. Prior to starting the doctoral program here at Emory, Swathi completed her MPH in global health with a focus in nutrition. She then served for a year in India on the Clinton Fellowship for Service, followed by 4 years at the Centers for Disease Control and Prevention in the Division of Diabetes Translation. Her long-term research interests include increasing and improving multi-level interventions for diabetes, including the role of social support for diabetes prevention and management among South Asians. And with that, I am very happy to welcome you here, and we're looking forward to your talk today. Thank you.
Thank you. That was so nice. It's funny, you just said, you basically just gave a summary of what I'm going to talk about today. Like, you said social support like 4 times, and that's what this entire presentation is about. So that works really well. Thank you all for, I'm just gonna write here so I can actually see. We'll see. I'm gonna move this.
There are mics in the ceiling.
There's mics everywhere? Okay. So I appreciate everyone for folks that were able to come in person and anyone that's online. My name is Swathi Sekar. I'm very grateful to have this opportunity to speak to this center. I've seen a lot of the previous presentations that this center has given, and I think it's wonderful that Emory has this resource here and has so much support around diabetes research. I think it's, when I was getting my MPH here, like 4,000 years ago, I didn't come here knowing that I was gonna be interested in diabetes work. I was really motivated by the folks in the center and y'all, people that are in this room. I've known Lisa and Mo for many years now, and it's been great, and I'm really grateful to be here. So thank you so much. And with that, I will get started by pressing this clicker. Right place. I'll use this. Maybe I'll just do that. That worked. Wait, that's my laptop. It's not gonna work. Let's see. Okay, we'll just do that. If the clicker doesn't work, it's okay.
You can also press the screen.
Oh, really? Well, that's nice. Okay, I'll try. This, for folks that are online, there are like 1, 2, 3, 4, 5 massive screens in this room, which is really slightly intimidating. But yeah, here's a really broad agenda for what we're planning to follow today. This is part of my dissertation work. This is the first aim of my dissertation, and it's a work in progress, but it's something that I've been working on for quite some time now, and I'm just really excited to have this opportunity to talk about it. I haven't really had the chance to talk about this aim in a formal capacity after I really worked on it, after proposing it. So this is really exciting for me, and I welcome feedback. We'll have time at the end to provide feedback, but if anyone has to leave early and wants to provide feedback during the presentation, I welcome that as well. It's quite informal from my perspective. So I'm going to start with some background, but I know that the people that are in this room don't need any background. I'm doing that for the few people online that might want some background into this field. And then we'll move into the theory, that like the theoretical foundation of my work. And my department here at Rollins, the BSHES department, is very, very committed to this idea of research being rooted in theory. And it's one of the many reasons that I decided to join that department. And I strongly believe in the power of theory-rooted research. And so there will be an element of this presentation that talks about the theory that kind of informs the various aspects of this review. We'll then talk about the eligibility criteria for the systematic review. We'll go through the flow of how we started with thousands and thousands of search results, and we narrowed it down to very few, 26, and then actually even slightly fewer than that. But yes, we will go through the process of how that happened. And then we'll talk about some of the preliminary results from those papers, conclusions and key takeaways, and future research kind of opportunities, including kind of how this feeds into my other two aims of my dissertation.
They had to make a talk.
For a brief background, we know that diabetes is a leading cause of disability. This is not just in the United States, but globally. We know that diabetes is a very costly disease. We know that that cost continues to increase year by year. What's important to note here is that I think there are countries like the United States that have comparatively stronger infrastructure to handle this increased cost. And then there's other countries around the world that do not have that strong infrastructure to handle this increased cost. And as a South Asian myself, and a large motivation of going into public health was to really try and address public health issues, not just from the standpoint of countries that have strong health infrastructure, but countries that also probably struggle with that in comparison to the United States. Hence this focus on South Asia, and not just South Asian countries, but this review also includes South Asians that live outside of South Asian countries, and we will also, I will explain or list out the countries that are designated as South Asian countries. And then finally, we know that diabetes is increasing in these developing countries at a more rapid pace now compared to developed countries. And some of that and there are many reasons for that, but this was also, some people will say that developing countries are where developed countries were a couple decades ago, essentially. And so we have developing countries that are now that they have rates of diabetes that are going up rapidly, and the South Asian region of the world definitely falls in that category. So with this, now shifting to this focus on South Asia, the number of people with diabetes will increase, will continue to increase. So we can't necessarily say if the rate will increase at the same level, but in terms of raw numbers, the number of people with diabetes will continue to increase in these South Asian countries. And that doesn't even include all the people that don't have their diabetes diagnosed yet. So we're only talking about people that actually have diabetes or pre-diabetes diagnosed. And so if you look at India and Pakistan, two of the countries that are included in the South Asian region, 74 million of those don't even include the folks that have not had their diabetes diagnosed. I know the people in this room are very familiar with the Masala study, mediators of atherosclerosis in South Asians living in America, MASALA. So it's just an amazing, I mean, I've loved reading about it. I've loved learning about it. It's this amazing wealth of data that is entirely focused on this topic that I really care about. It's really wonderful that it exists. It's a U.S. longitudinal cohort of South Asians, and it really gives us this really helpful information on how the prevalence of type 2 diabetes is different among South Asians as compared to white Americans, African Americans, Latin Americans, Chinese Americans. And we can also look at the cross-sectional age-adjusted analysis of these data. These results are, although they are cross-sectional, they are also age-adjusted, which I think is also which provides really helpful information, not just for my own research, but I think it's a really wonderful wealth of data that we have at our fingertips. So what I'm trying to do with this review is talk about how these, we know that higher levels of support, even if we're just going with our own common sense here, we know that higher levels of support are going to are showing improved clinical outcomes. You can assume that if you have people supporting you in whatever capacity that is, and we'll go into how I define social support, we'll go into how it's defined in this work, but you can assume that people who have support are going to have more resources to be healthier. If you have someone living in your home that's helping you manage your diabetes, the chances of you having improved clinical outcomes are increased. And you don't necessarily need to have a PhD and do research to know that. I think you can probably just assume that from the people that you know, from the communities that you live in. And we also know that having family support in the context of things like diabetes self-management education, those have shown to have positive impacts on patient outcomes. And so we know that like including family engagement can be a really promising direction for improving diabetes care. And we also know, we've also talked about how there are these high rates of diabetes among South Asians, and we also know that lifestyle interventions are also they also have promising results. However, having an actual review of how all of this plays out in the South Asian context does not exist yet. So my goal here was to look at not just diabetes interventions and look at not just the South Asian community, but try and see if I can really tease out what are these social support elements in diabetes interventions that are being used, how are they being used, and what types of outcomes are being explored within these interventions. I'm trying to see if I can, we will kind of get to this towards the end of the review, but a spoiler alert with like some of what I found is that there's a very, very wide range of kind of sample sizes, a very wide range of how long the intervention actually was taking place. That makes it sometimes difficult to kind of just say that if you have this specific social support intervention, you will have a waist circumference decrease in this many years. Like, I mean, some of the system, because there's such a broad range of kind of intervention related details and the intervention components, it can be difficult to make those connections. But that's the goal of this review, is to kind of see what's out there, see what interventions are out there, what are the social support elements that are being focused on, and how are they being utilized in this particular community, not just in South Asian countries, but across the globe. All right, so we are looking at social support theory as the kind of the rooted, we are looking at social support theory as the foundation for this review. And there are many aspects of social support theory, but there's essentially these two main mechanisms. There's this stress buffering model or this direct effects model. And broadly, they are suggesting that social support can be health promoting because social support can influence psychological processes, they can influence behavioral processes, and the stress buffering model is suggesting that the stress buffering model is suggesting that social support is diminishing negative health effects of stress. And then the direct effects model is generally talking about the health enhancing effects of social support. So we're either talking about how stress diminishes or how social support can enhance positive health outcomes. So we're also saying that this theory is also saying that the stress prevention model was highlighted in this early review where they really needed to emphasize this stress prevention. And these models have, so this theory has been around for quite some time, but we are using it as the motivation behind. We're using it as the foundation for this work, but it is not going to be the entire focus of how I identify constructs for this review. So I'm sorry that was a little bit confusing, but I'll break it down over the next couple slides. So essentially, if you're looking at social support, you'll see that this is somewhat different from how the original theory was laid out. But social support has these two main concepts. You have structural support and you have functional support. And you can essentially say that one establishes structure, and then the other one examines the functions that come from that structure. So you have structural support that have things like whether or not someone is married, whether or not someone is part of some type of social network, whether or not someone has any type of social integration at all. And then from that structure, we can identify what functions of support are actually emerging. So you can have informational support, so things like providing recommendations, providing advice, other helpful information. So you can have tangible support, which is talking about financial support, material support, physical assistance, for instance. You can have emotional support, which is expressing affection, expressing empathy, caring. And then you can have belonging, which is being in the presence of social engagement. So you have the existence of structure, and then from that structure, you have different functions that structure can provide somebody. And also just to break down a little bit the difference between social networks and social integration. Social networks will be like things like how dense your network size is, how many social contacts you might have. Social integration is things like being actively involved in social activities, being actively involved in a variety of relationships, and having a sense of community, essentially. So that's kind of how oh my gosh, hi Brandy. That's how these are the various constructs of a social support that I have been looking at through this review. So we saw the original theory and kind of the original processes of the theory, but I've used that, focused on the direct effects model, which was the second. So like if I go back and show you guys this, so we have we have the stress buffering model here at the bottom, we have the direct effects model here at the top, and it's the direct effects model that I've focused on for the conceptual model for my dissertation work. So we aren't necessarily going to go into every single aspect of this. This is for all of my 3 aims, but we will be focusing on a range of social support constructs, and then we will also be looking at health outcomes. And we will be trying to make that connection, and you'll see I will try and break down which social support elements are more strongly connected to significant diabetes and psychosocial health outcomes. That's the goal by the end of this presentation. We'll see. So then y'all can help me out too, because it's complicated. So we have multiple research questions for this review. We're trying to look at levels of intervention, so we're not looking at just individual level interventions. So we're trying to, social support exists on the interpersonal level, and we are trying to, so inherently the review lends itself to interventions that exist on more than one level, but that doesn't necessarily mean that it has to just be the interpersonal level. Some of these social support interventions will include community health workers, which would be considered a community level of a support, but I'm trying to look at what are these different levels of intervention for diabetes prevention and management that include these different types of social support components. What are the actual types of social support that are offered by these interventions? And what are the components of those interventions? And then what are the outcomes? What outcomes are coming from these interventions? So one of the requirements to be included in this review is that the intervention actually is exploring outcomes. They can be qualitative and quantitative outcomes, but regardless, every intervention has to have some exploration of health outcomes. And we will go into that as well. So we're talking about exclusion criteria. It needs to be, the intervention needs to include, or the paper, not the intervention, like the actual paper to be included in the review needs to include South Asians. It needs to be a intervention study that has social support components. The target population are people with diabetes or pre-diabetes, and it has to be peer reviewed and published somewhere between 2000 and 2022. And we're excluding some of the common things that are usually excluded from systematic reviews, like abstracts, papers that aren't in English, if I can't find a full text. But generally, we try to include as much as possible at the first stage. So we were trying to capture as much as what was available out there in the literature. So the methods, we went through there were a lot of databases that we searched. There was definitely help provided from the Health Sciences Research Library, which was wonderful. I worked with a few master's level students to help with the initial stages and kind of identifying duplicates and things like that. And we used a software called Covidence to do this work. And there's a very, very wide range of search terms that we use. Here are some examples of those search terms. It's not everything, but to capture the concept of social support wasn't the easiest thing in the world to do. Like, I think capturing what social support actually is from with search terms, we had to change things up at different points in time if we were realizing that we were capturing things that had nothing to do with social support, or if we felt like what we really wanted wasn't coming through the search. But we ultimately had terms such as community health worker, village health worker, making sure that the word peer was in there, the word family, but the social support terms was probably the largest chunk of terms that we used for the review as compared to everything else. I think the other categories of terms were a little bit more, were inherently more specific. Like geography-wise, we just went with World Bank South Asian countries, essentially. So we went with Afghanistan, Bangladesh, Bhutan, India, Maldives, Nepal, Pakistan, and Sri Lanka. And we used the World Bank South Asian countries to identify what would be considered South Asia. And we used not just the country names, but Indian, Bangladeshi, Bhutanese, and we made sure that all of those people that were not necessarily living in those countries were also captured in the search. We had diabetes prevention and management mesh terms. And the other aspect that was not very easy to capture, but we didn't use nearly as many terms to cover intervention studies as much as we used to kind of capture different forms of social support, because a lot of intervention studies do somewhere in the title or the abstract will usually include the word intervention. So we use the term intervention, of course. We also use terms like reduce or control, prevention, management, and we essentially, if most intervention studies, if they're going to present and publish on an intervention, the term intervention is most likely going to be in the title or the abstract, because it's essentially it's the reason that they're publishing this work. So the search process was it took a while. There were multiple iterations of it, but that's kind of what we ended up with. So I'm going to go through the flow. So we started off with about 2,600 references that came through these databases. Many were duplicates. For anyone that's familiar with systematic reviews, this is very common, because you're pulling these papers from all these different databases, and the databases are not mutually exclusive, obviously, so you're going to get a lot of duplicates. We did screen over 1,000 studies, and I was very grateful to have the help of master's students to be interested in this work to help me out, and because it takes time to do that. And granted, if we weren't screening the whole paper, we were doing title and abstract screening to bring it down. And then we we screened those 1,200, and then we excluded 951 based on our criteria for what needs to be in in this review, and I will give you the entire list of criteria after this. You'll notice in this flow diagram that I've grayed out the sections where we have excluded studies, and then once I go through the whole flow diagram, I will show you the list of criteria that we use to actually exclude those studies. Then we assessed over a few hundred full text studies, or full text articles. We went through the whole article, and then based on what we read, we excluded another large chunk of those articles. Ultimately coming down to 40 articles, another 14 were excluded, and then we ended up with 26. So why were studies excluded? This is like a big question that everyone asks in systematic reviews, because you're really trying to present accurate information, really trying to produce something, like really trying to publish on a topic that can be very useful to other people that are in this field. You want to be clear about why you are selecting studies, why you're not selecting studies. And so these were the key reasons for why papers were excluded at various stages in the process. Sometimes we would find that because of some of the search terms that we use, because it's not necessarily the easiest thing in the world to identify things like if something is really an intervention, many of the papers ended up not being intervention studies, or there was actually no social support component at all. It was perhaps a diabetes intervention, but did not include any type of social support. Perhaps it was American Indians versus Indians from India or Indians from the diaspora. So perhaps it wasn't a South Asian population focus, and that would have been a reason for exclusion. And I realize now that I'm speaking out loud about this, this is not really listed in order of what was the most common reasons for exclusion. And I'm thinking to myself that when I present this for my defense, I should put it in order. But there were a lot of papers that just didn't have any outcomes at all. And that was a key reason for excluding them, because we really wanted to see how these interventions tied to some type of diabetes or psychosocial outcome. And then finally, if it wasn't a diabetes-related study, we were not able to include it in this review. And like I said, we used COVID to do this. So here are some results. Many studies most of them were outside of the United States. And that doesn't necessarily mean that they were all in South Asian countries. I mean, the vast majority of the papers that were from South Asian countries were based in India. And then the other papers that were not or the other interventions that did not take place in the United States were mostly in other Western countries in Europe, Australia, Canada, those kinds of things. The interventions had a very, very wide sample size range. We are talking about anywhere from 10 folks to 50,000 people. And so very, very wide range of people that were included in these interventions. We were, the average, like the mean age of participants in these interventions was about 54 years old. There was also a very wide range of how long these interventions took place. Some of them took place over the span of 10 weeks, and some of them took place over the span of 3 years. We had a range of intervention designs. 15 of these interventions were experimental, essentially randomized controlled trials. 7 of them were quasi-experimental, so they had a control element, but what wasn't necessarily randomized. And then observational studies, for instance, like some type of cross-sectional study, for instance, that did not have a control element. All interventions, like I said, for them to be included in this review had to be multi-level. So they were all multi-level interventions. Many of them had individual and community level included. Some of them had individual and interpersonal level. So we're talking about interpersonal as in like a spouse, for instance. And then a few of them, 3, had individual, interpersonal, and community levels all incorporated into the same intervention. Now, when we're talking about social support, there are different forms and different sources of social support. And there's different components of a social support intervention that came through this review. So you can receive support in from different types of people and through different mechanisms. So on the left side of the screen, you see the intervention components. So things like, was the social support provided through an educational session? Was it provided through some type of dietary intervention? Was it through some type of group exercise program? Was it a peer support intervention? Was it led by a community health worker? Was it possibly technology driven, like through text messages or through an app of some kind? So there's different versions or different components of social support interventions, and these were kind of the broad categories of what came through these different social support interventions. And then there was also a wide range of people that actually provide these interventions. So the majority, a larger portion of these interventions come from professional support people and a support staff, and then a smaller portion of them come from what research terms as lay support. But I don't know. I every time I write that or say it, I kind of feel like I want to change the term, but I don't really feel like that's a conversation for a whole other day. But in terms of professional support, we're talking about things like physician. We're talking about people like physicians, counselors, trained project staff, people that have a degree in people who are dietitians with a degree in diabetes education, for instance, or trained community health workers. And then lay support are folks like peer facilitators, volunteers in the community, peer leaders, or community health workers that might not necessarily have training as a formal community health worker. So these are the different sources of social support that came through in this review. And then in terms of the types of support that we find informational support rising to the top more than any other type of support, which I think many people would probably assume. Informational support is in many ways the one that's, in many ways easiest to provide, but also we found, and the reason that the final studies didn't end up staying, like the reason that we had to drop a few of those final studies after we included them in the review is because we found that informational support isn't always support. Sometimes informational support comes through as just you sitting in a clinic with your doctor and getting your blood drawn. And a social support intervention might include that as informational support. And because the doctor is saying something to you about your diabetes, but we had to rethink how we use this informational support in our review. So you'll notice that we also examined how many of these interventions include a type of support beyond informational support. So all of these, so the bar graphs at the end, so 6 and 15, were all interventions that include informational support, but also other forms of support. So we ultimately only ended up dropping the interventions that did not have any other form of support besides information, because we decided that alone did not fit into our definition of what social support would fit into our definition of the benefits of social support. So we have informational support, followed by social integration, followed by emotional support, belonging, tangible, marital. And we found that on average, interventions provided over 3 types of support, which was really great to see. So as I know this is and also some of these terms, I'm assuming some of these terms might feel like they overlap some, which they absolutely do. I wanted to also provide some examples of what these different types of support look like from the standpoint of these interventions. So for informational support, you might receive some knowledge about how diabetes develops for an individual, any type of dietary requirements once you've been diagnosed with diabetes, or just making sure that you adhere to whatever medication you might be on. That would be considered informational support. Social integration, for instance, a Bollywood dance class, 1 hour each, twice a week for 10 weeks. That would be considered an example of a type of support that involves social integration. A type of intervention that would involve emotional support would be perhaps having a community health worker come to your residence monthly as part of the intervention group that the control group might not receive. Belonging would be possibly 15 consultations with a dietitian where both the participant and a family volunteer were involved. So because with belonging, if you recall like the definition of this belonging type of social support, we're talking about people that feel like they are part of some type of community of some kind, or have support, or have other folks in their circle that they feel like they can rely on. So the idea was that these interventions would include some of these other folks that might not actually have a diabetes diagnosis, but are part of the intervention. And finally, tangible support, an example of that would be being provided equipment to measure, record daily blood glucose and blood pressure. Okay, so we're coming towards, I'm just checking the time, I wanna have a little bit of time again. Okay, so we're talking about outcomes. I tried to split the outcomes between diabetes related outcomes and then behavioral and psychosocial outcomes. So there was a wide range of diabetes outcomes that were explored in these interventions. We looked at waist circumference, fasting blood glucose, BMI, systolic, diastolic blood pressure, HbA1c, and weight. And unlike a few slides ago, I actually did order these by most to least, which I think helps. I'm like in real time critiquing my own work, which is like hilarious to me. Okay, and then among the psychosocial and behavioral outcomes, we found most interventions were exploring diabetes knowledge, followed by physical activity, followed by fruit and vegetable intake, then diabetes empowerment. We also included social behavioral health concept of self-efficacy, and then medication adherence, followed by psychological distress, or diabetes distress would fall in that category as well. And then 8 studies had both diabetes and psychosocial outcomes. You'll notice 2 outcomes, or 1 outcome in each of these columns has an asterisk, and that indicates that was the outcome that had the most significant results. So as opposed to, because all of these papers would indicate whether the outcomes were statistically significant versus statistically not significant, but as public health researchers, we know that it's not as clear cut. I mean, something that might not be statistically significant might have other types of significance, might have clinical significance that should be taken into consideration. But essentially, the asterisk indicates that was the outcome that had that showed up as statistically significant in the most number of studies. So finally, just to talk about some conclusions, key takeaways, and then I'll talk about some limitations and future research ideas, and then we can take some questions or have discussion or anything that works for folks. So essentially, I've loved being able to do this work, because I really feel like I've had this opportunity to dig really deep into a underrepresented group in public health research and diabetes research, and I really liked being able to explore a community that I come from. I've also been able to highlight this role of social support. When you look at South Asian communities, many of us do really rely on these large communities of support. You go to an Indian wedding, there's going to be like hundreds and hundreds of people there, and mine had hundreds and hundreds of people there. And it was like, we really do thrive on this element of having support from our community. And I really enjoyed being able to structure a dissertation around this topic as well, and see how social support can actually be linked to positive health outcomes for folks that are living with diabetes. We learned from this review that after accounting for informational support, which we know was coming through as the most common type of support, the next types were social integration and emotional support. We've learned that professional support was more common than getting support from a lay health worker. I've really enjoyed this. One of the reasons that I've kind of gone into this particular lens of diabetes research is because I have really enjoyed the process of looking at diabetes from this multi-level way and looking at it from, although everybody can agree that diet and physical activity are key to diabetes prevention and management, I have really liked looking at diabetes and looking at diabetes prevention and management from this multi-level way, because not everyone has really the capacity to change diet and physical activity as easily as other folks. And I've really enjoyed kind of being able to bring social support into that conversation. And then, so I think this last bullet I've already really talked about, but essentially advocates for, I really like that this review also advocates for culturally competent interventions that target not just individuals, but households and communities, because households and communities are so key to the South Asian, to the South Asian world, essentially. So, in terms of limitations, I mentioned this a little bit. We have a very wide variety and types of interventions that sometimes make it difficult to link intervention components to actual significant outcomes. However, this is, I am trying to do more of that in my other dissertation aims, and I will talk a little, I can talk a little bit about that as well. But in terms of how to make a review like this even more nuanced, it would be really, really interesting to break it down into more regional differences, break down diabetes and psychosocial outcomes into more nuanced results. As I mentioned, this is my first dissertation aim. My second one is a quantitative aim that looks at the role of community health workers as a form of social support. And then I have a qualitative aim that looks at the role of spousal support for diabetes prevention and management. My second aim is also includes behavioral mediators like medication adherence and diabetes self-management as part of the pathway from a social support, or from a diabetes intervention to a positive health outcome. So I'm happy to answer additional questions about my other dissertation aims and all of that as well. But yeah, that's it. I wanted to thank my committee. Dr. Escofri is my chair. Dr. Khan Escofri, Dr. Muhammad Ali, Dr. Megha Shah, and Dr. Regina Harderfer. I have a phenomenal committee, and they've all been incredibly supportive and really provide very, very helpful feedback. And then I wanted to thank my research assistants that helped me kind of get all of these papers reviewed, because it's a lot of reading and a lot of, dissecting lots and lots and lots of words. So, but yeah, I really appreciate everyone taking the time to be here, either in person or online. I'll check and see if there's anyone, if there's folks still, if there's any questions or anything. But yes, I appreciate the time. Thank you very much.
Swathi, that was very nice. This is Mo. Can you hear me?
All right. Anyone have feedback or questions? I can go back to some other slides. Oh, yes, please. Yes, Lisa.
Were the studies presumably mostly cross-sectional, or were any of them longitudinal? There were longitudinal studies, but they were part of. I can go back and look and tell you how many of the experimental interventions were longitudinal. Not all of the experimental interventions were longitudinal, but some of them were. Yes. So, and the reason for that is that I think that you could postulate that majority were cross-sectional, then potentially have an underestimation of social support. For example, if you have someone who's got extremely uncontrolled HbA1c, and if the timing in which their social support comes in happened, you know, a little bit earlier, whatnot, it's possible that a poor A1C is actually reflective of an improvement from like a 13 to an 11.
Yeah.
Even if it's in this kind of extreme uncontrolled category. And so, you know, how do you account for that in this kind of analysis? Yeah, and maybe, you know, is it worth looking at the longitudinal studies separately? Yeah.
Yeah, that's a really, really good point. I completely agree. I think they definitely, when you do a review like this, some of these interventions tell a completely different story than the other ones. And yeah, I think you make a really good point. I think looking at the ones that have longitudinal data and can tell you exactly when the social support component came into the picture.
Swathi, this is Mo. Can you hear me?
It's very
You
nice.
did a great job.
Thank you. I'm so happy you're here. So nice to see your face.
So when you get social support, you're not looking at any family members, just you said marital in your second aim, but no one else in your family?
Okay, this is a great question. So my second aim is focused on, I'm looking at the role of community health workers, but in my qualitative aim, you're right, I am focused, I've decided to focus my qualitative aim on spousal support. But that's not I mean, there are pros and cons to that, to that decision. I think there was a lot of back and forth on whether my study would be enhanced or would provide, we felt that expanding to children in some of the interviews would take away from the final story of household support. And so we decided, for the sake of uniformity, to go with spousal support. But yes, there are pros and cons to that, and it's absolutely true that that there are other additional questions that we could absolutely ask if we were also including children, for instance, or grandparents or grandchildren, for instance, into or siblings into the Did you have another thought about that? Okay. No, but you bring up a really good point. We went back and forth on it. Yeah. Yes.
There's a question from Herman Taylor.
Okay.
How are the issues of
Heterogeneity.
Thank you, of SES and social position approached in the papers and your analysis? The community is so vast and diverse across the planet. Such issues make for rich subjects for further exploration. Congratulations on your research direction.
Oh, that's so nice. I'm trying to see this.
Dr. Taylor's hugely at Morehouse.
I'm sorry. Yeah, I was gonna say yes. Well, no, this is a great question. One of my original versions of not just this study, but my dissertation broadly did have some stratification of SES incorporated into it. And I think this is, I mean, you're absolutely right. I think it's definitely a factor, and probably is an opportunity for a more nuanced kind of exploration into social support and how social support looks depending on what social economic status or what community you're actually a part of. But yeah, no, this is a great point. Thank you.
Something else from Megan Shaw.
Okay.
She says, I'm wondering if you have some final thoughts on essential components if you were to design the ideal social support driven intervention for diabetes management.
Yeah, I love it. Yeah, Dr. Shaw is on my committee, and I think this is, I think from reading all these papers and reading all these interventions, there are certain components. What I think really needs to, what I need to dig further into is see if I can really, because I wasn't able to find any one of these components really rise to the top versus when I was looking at different forms of social support, I was able to see the forms that were rising to the top. But in terms of the like ideal intervention component, in this particular review, I wasn't able to see one that was really showing up over and over and over again. But I think, I don't know, I think it's like, I think what I really need to do is go back to the papers that have significant, I need to go back to the papers that have significant health outcomes and have statistically significant health outcomes and look and see what are the social support components that were part of those particular interventions and see if I can form some type of link between those types of interventions, because that's the only way I can really think of how to actually answer this really, really good question, because I think that is like the $1 million question. It's like, how do we structure the most helpful social support intervention for diabetes prevention and management among South Asians? Like, I think that is the $1 million question. And this review didn't seem to indicate there was like one component that was really rising to the top. But I think if I go back and look and see which papers have significant health outcomes and what are the components of the interventions that really link to those health outcomes and see if there's some uniformity there, I can maybe kind of go into telling a little bit more of that story. But yeah, thank you, Dr. Shaw. That was this is the question that I know that everyone is going to be interested in. So, and I'm sorry, I saw that you said that you don't think that the mic was working.
I think it was on, but I'm not sure what happened,
but hopefully the folks online could hear some, and maybe was just having some trouble towards the end. I hope you guys could hear most of it, and I know that it was recorded, and I know that it'll go on YouTube. So I hope y'all will get a chance to be able to listen in if it was difficult to hear it. So.